So now we're going to talk about the Gow-Gates mandibular block. We are not going to be learning the Gow-Gates mandibular block, but if you can learn this out when you're out in the field, just the more injections that you can learn, the more you just have in your toolbox for unforeseen things that may happen, and it just gives you a better range of injections to have. So this Gow-Gates, Mr. Um, Gow and Mr. Gates are the ones that came up with this, and so that's why they call it the Gow-Gates. It's a mandibular block. It's recommended for procedures during the quadrant of dentistry, or let's say that you've given the IA block and it fails. It's just, they are not numb at all. You can try the Gow-Gates. So this is the one injection that is called the true mandibular block. And I've seen that question in review books. It'll ask, what is the true mandibular block? And it will give all these different injections. It would be the Gow-Gates. And the reason that they call it the true mandibular block is because it gets everything. You know how the IA will get partial. You have to do the IA and the buccal. And so this Gow-Gates, you just give one and it gets the buccal. So it gets even things we don't need. It gets the mylohyoid nerve. It gets the long buccal. It gets the mental. It gets the incisive. It gets the inferior alveolar nerve. And it also gets the auriculotemporal nerve that we don't need, that is up kind of by the side of the face, by the back behind the eyes, or I should say this to the side of the eyes, up on your temporal. So it gets everything. It provides sensory to the entire distribution of V3. So cranial 5, it should get the third tier of that. And this is showing, you can barely see the pink around there, but it definitely gets, you know, from here, it gets all that soft tissue. It gets around the distal. It gets around the buccal. It gets the soft tissue and everything of this whole entire arch. Now, where you contact bone here, you go in almost like you're going to be doing an IA, except you go higher. You go higher right underneath the maxillary arch, actually, and where your target area for the GG, or for the Gow-Gates, is up at that condyle. So you go way up there, you use a long needle, and you go in almost to the hub, a good 16 millimeters, like as if you're doing an IA, but you are going further in, and you need to contact that bone so that you know that you are where you need to be. On this injection, you do the mesial palatal cusp of the second or third molar, and so this is why that cotton tip applicator is moving straight up. You can see that they're going from the contralateral side of the mouth, and it's the corner of the mouth. That's where your syringe is going to go to give the that side of the mouth of the Gow-Gates. And you are going to, you put the cotton tip applicator at that mesial palatal cusp, and then you move it back behind or distally of all of the teeth, and then that's where you would inject. This is a far better and more realistic picture of what you're actually going to be looking at. So the needle is going to go behind or distal to the last molar, but it's up at the height of the mesial palatal cusp of the second molar, or possibly the third if it's there. So that's how you can tell how high it's going to go, and then you just move it distal of the last tooth, and there you'll inject there. On this particular injection, like the IA, the patient has to open as wide as they can. On this Gow-Gates, it's super important that they do that, or the condyle is not going to be in the right position, and so they have to have their mouth open really, really wide. So a contraindication of this particular injection would be people who can't open their mouth very wide, or they have trismus, or some kind of condition where they can't open their mouth wide. They would not be a good candidate for the Gow-Gates injection. This shows you what you can line up with. You can line up with the corner of the mouth on the commissure and all the way straight across to the tragus of the ear. And if you make an imaginary line between those, that's the direction that it's actually going. You feel like when you're in the mouth that it's going completely up, but it's going up and back, and that's where it's going to be contacting the condyle. So the advantage of giving the Gow-Gates is it anesthetizes the buccal soft tissue. So you don't have to do an IA and then swing around and give a long buccal to that mandibular. You can just give the Gow-Gates, and it has a higher success rate than the IA, and the injection lasts longer than the IA. The disadvantage is the operator's learning curve, and the anesthesia of the lower lip that you might not need, and the temporal area, which you definitely don't need. So it can come in and around their eye, a patient's eye, which can sometimes be uncomfortable. It does not anesthetize the eye exactly, but it's right around that temporal area, and they can get a little uncomfortable with that. So a contraindication would be, like I said, patients with trismus or with a limited ability to open their mouth. Any complications with this, you can develop a hematoma. If you do that, you're going to apply pressure with gauze to the area and just reassure the patient. I added this injection along with the Gow-Gates. This is called the Vazirani Akinosi. This is a complete closed mouth injection. Dr. Akinosi and Dr. Vazirani developed this from the inspiration that they had from a Gow-Gates. And so they realized that you can't give the Gow-Gates to people with limited opening, so they developed an injection that you could give to patients that had a very limited opening or couldn't open their mouth hardly at all. So this is an extraoral mandibular block through the sigmoid notch, and you can give it extraoral, ouch, or you can give it intraoral, which is the one that's given more frequently. So if you look in your book at the pictures, you'll be able to see that they can go in extraorally through the outside of the cheek, and they go in that way if it's a really dire case. But if someone can open their mouth even just a little teeny bit, they can give it intraorally, which is far better. And so it's only given for those people with limited openings, and you'll need to know that. This is the target area for the Vazirani Akinosi nerve block. And so someone whose mouth cannot open any more than this picture is showing, they can go in and go just straight back and try to hit that lingual nerve right from that very area. So that would be good for them. And like I say, they can also go from the outside. And don't worry, you're not practicing either of those on each other.